You know, it's not fair. For little people like me, everything's so tall, right? So it's my distinct honour to welcome all of you to Alberta Innovates, Edmonton Research Park this morning for the inaugural dialogue forum for our community of practice for supply chain resilience and Canadian health systems. I, of course, could not be here today without recognising our land acknowledgement. And I'd like to read this. So Alberta Innovates respectfully acknowledges that we're situated on traditional territory of the Treaty 6, Treaty 7 and Treaty 8 First Nations, home to Métis settlements, the Métis Nation of Alberta, and regions 2, 3 and 4 within the historical Northwest Métis homeland. We respect the histories, languages and cultures of First Nations, Métis and Inuit, whose presence continues to enrich our very vibrant community. And we offer this land acknowledgement as an opportunity and an important component of reconciliation between non-Indigenous and Indigenous peoples of Canada. Thank you. As you heard, I'm Laura Kilcrease, CEO of Alberta Innovates. If you don't know me now, you will know me at some point. I'm a crazy lady. There's nothing that we can't do if we believe that it's of a nature that will make a difference in the lives of not just us, but others. Our passion will come through. This facility that you're in today, unfortunately, a lot of the areas are closed off, but should you want to see a couple of the areas, please let Cindy or one of the other people know, and between perhaps breaks, they'll maybe get 5 or 10 minutes to take you to a couple of places. But there's a lot of very, this is the place where for those of you who may be more local or in the oil and gas business, SAGD, steam assisted, the more environmentally clean way of getting oil out the oil sands was developed over a decade ago. This is the place where we're developing the future in many areas, oil and gas, agriculture, biomaterials, water remediation, etc., and where we work with industry. This is one of 11 facilities we have across the province. Of course, in your particular area in health, I want to point out our VP of Health here, Tim Murphy, who's sitting in the second row, without whom I could not do anywhere near what we need and have accomplished so far in the healthcare portfolio. And we don't just accomplish things, and you'll hear more about this, I'm sure, as you all talk today. We actually measure it, and we have Catherine Graham at the back, who is world-class, literally. She runs the International Association, or co-chairs, for performance management, where we set up frameworks and measure what we're doing, and not just in traditional ways of jobs and exports and companies, but in perhaps the less traditional ways of diversity, equity and inclusion, ESG, frameworks for emission reduction, all kinds of things like that. To say but a very few, and that woman is so brilliant, I won't go any further because you'll see how brilliant she is that I can't even explain some of the things she does. Yeah, thank you. Hey, I like this. But Alberta Innovates, for those of you who don't know, is the province's largest research and innovation agency. We're looking to solve, as you may have got from what I've just said, not only today's challenges, but create new opportunities to forge a very healthy, sustainable, and importantly, prosperous future for not just Albertans, but people across Canada, and then globally how we can interact and share our knowledge with others. So when Anne approached us with an opportunity to join this Canadian-wide partnership grant, we were absolutely ecstatic, because the goal of the community is practice alignment that's very much in line with our own thoughts. You know, we do have, and you probably know better than I, the one healthcare system today that affords us some luxuries in terms of data and other unique aspects that may not be quite as easy in other jurisdictions, wherever they are in the globe. But having said that, there's so much more that we have to do together. And the community of practices provides us this opportunity to connect with colleagues outside of Alberta who may be experiencing similar challenges to us. I want to really emphasize that again. You know, the fact that you're here today, I'm sure it's some of Dr. Snowdon's persuasion as well. But the fact you're here today speaks volumes about who you are, singularly and collectively. Because as we go forward in this post-pandemic world, it's not about I, it's about we. And I think as you get to know the we amongst you today, I think you're going to be not just outstandingly impressed with your colleagues, but you're also going to have opportunities to forge relationships for a long time. And during the pandemic, we lost that opportunity to forge those relationships. Yet going forward, we're going to need them as a country and for us as a province more than ever before. So I encourage you not to just think about this as something that's very important around the community of practice that you're going to be talking about today. I actually challenge you to bring your best thoughts forward, your worst fears forward, and find ways amongst all of you to solve those issues while you take away something for yourself from these conversations. I hope to think it's the start, every one of you will have the start of a brand new friendship going forward. So it allows us here today to share your expertise, drive new ideas, support the development of effective strategies. And I look forward at some point to connecting with all of you. You know, it's probably very patently obvious to most of you, we ourselves in Alberta are in the middle of a leadership transition over the next few days. So unfortunately, I will be in and out, and probably more out than in today, but I'll certainly hear about this both in a post-discussion with Anne and Tim and many others of you, I hope. So you don't need any more of a speech from me. If you remember one thing, the one thing is do good work, make a new friend, and go away here knowing you've made a difference in the world. And with that, it gives me indeed an enormous pleasure to introduce my friend, Anne Snowdon, Principal Investigator on the SSHRC grant to build the community of practice for health supply chain, and is also the CEO and Scientific Director of Scan Health, Professor of Strategy of Entrepreneurship at the Odette School of Business at the University of Windsor, Chief Scientific Research Officer of HIMSS, and I can't miss this out, my Vice Chair, so I better darn do what she says. So thank you, Anne.
As always, Laura is an incredibly hard act to follow. And her reference to crazy lady couldn't be further from the truth. She is probably one of the most talented and inspiring leaders I've ever had the privilege to work with. Her team in this room and everywhere else in Alberta Innovates will tell you that over and over again. She is an absolute. She's like a crown jewel, not just in Alberta, but in Canada. Alberta's just incredibly lucky to have her. So thank you. Thank you. As you all know, I'm Anne Snowdon. We wrote this grant and saw so much opportunity to really change the game in health supply chain. And health supply chain for me is not just about do we have the products and the supplies and the distribution to where it needs to go. For me, it's about human life. It's about quality of life, and probably on top of all of that, it's about equity. Does every Canadian have the opportunity to achieve their health goals, and where and how does a supply chain make that possible? So for me, on the basis of an awful lot of research, most recently, that's what supply chain in healthcare is about. But when you say those terms, supply chain, people think, oh yeah, those are just products and distribution. I said, no. That actually directly affects whether people live or die and whether people have those choices. So for me, it's exceptionally important, the work we have in front of us. It is not for the faint of heart, I would suggest. This is an awfully big and impressive agenda, and it simply is not possible with the leadership in this room and the incredible leadership and support of our partners. Alberta Innovates made today possible. Thank you, Laura, and all of her team. GS1, sponsored as well, made it possible for many, many things to unfold, and Shoppers Drug Mart, incredible support. So Karen Sullivan, you'll be seeing and hearing from her today as well. I cannot wait for some of the impressive opportunities to start to emerge. This is our very first forum to begin the dialogue and to start to set out what's possible, what's achievable, and where are we going to have the greatest strategic impact. Laura already identified Catherine Graham's brilliance. We met yesterday. She's going to be helping us capture that impact, demonstrate it, profile it, because in my experience, as you start to build momentum and start to achieve value and impact, it needs to be documented and it needs to be shared because it contributes to greater momentum over time. So Catherine, thank you for your willingness to support us today. Let me also express a warm welcome to those who are online. Not everybody could be in Edmonton today. We recognize the challenges of lots of other workforce and work commitments. So we are most grateful to have people join us online and not to forget that because they're not physically actually here. So let me just walk through. So what's the goals of this community of practice? It's a matter of not trying to solve world peace, but maybe close, but maintaining a very sharp focus on what we said we were about to take on. First and foremost, it is to advance, strengthen, mobilize, achieve supply chain resilience. The resilience is the ability to tolerate what we've just been through as a COVID pandemic and what we will go through in years to come. This is not the first time Canada went through this type of challenge, although it is one of the greatest scope and scale. I happen to have been a chief nursing officer during SARS. I cannot tell you the number of times I thought to myself, this is deja vu. I've seen this before, but of course in Ontario, it was much different than other provinces at the time. So advancing, supporting supply chain resilient will take all of us. The government, the health system leaders, the clinician leaders, the private sector companies, all of the supporting players and partners in the community of practice. We very much look forward to that. And supported and informed by citizens. This is a very unique opportunity where citizens will be in every work group because citizens live with the outcomes of all of these decisions in supply chain. So Judy Birdsall, we're most thrilled to have you and the Imagine Citizens team join us. The second thing we're going to zero in on, and I think you'll all agree, is a pretty critical challenge at the moment, and I expect it to be for years to come, and that's workforce. Workforce sustainability. In the early waves of the pandemic, as many of us were doing these case studies on what is our capacity to respond, it was crystal clear that the workforce were enduring tremendous challenge, impact, not just in terms of burden and workload, but in terms of their health and wellness. And we had extraordinary numbers of become ill and even die of COVID. So it's a significant challenge, which is deeply integrated with the supply chain capacity to ensure every worker everywhere, including essential workers across sectors, have that protective equipment and that protective environment to work with. And the third thing we hope to achieve is to start to co-design as a group, as a community, and test and implement strategies that make sure we never find ourselves in this position again as a country. That's a fairly tall order, but given the partners that are so generous and willing to work alongside us, I'm actually incredibly optimistic, and I must say deeply honored that those of you in this room and online are willing to work towards these pretty significant goals, knowing that every Canadian is actually depending on us to be successful. So not a small agenda, an impressive one, and this window of opportunity in the early post-pandemic phase, I think, is unique And this is the time where there's a tremendous openness, whether it's the federal government agencies, the provinces are all looking for what does next look like? What does great look like? And that's what we're, as a community, hoping to achieve. So let me extend my personal thanks for every one of you here and online for the willingness and the time and the resources that you've put in to make this possible. This is the first event of what we hope will be many, many very important, productive, and impactful events to come in the next 5 years. So thank you all. It is my immense pleasure to introduce Francois Bouchard from GS1 Canada. Francois will be introducing our keynote speaker, getting our program underway. And thank you again, GS1, for joining us today and being such an incredible support. They've put up with me for decades on this whole supply chain issue, so I'm so grateful you're still hanging in there with us to get this done. Thank you, Francois.
Good morning, everyone, and good morning, Anne. Thank you so much for this introduction. We were very happy to have you at the table, and we want to make sure that you're still around. There's lots that we can learn from you. So it is with great pleasure this morning that I'm going to be introducing our keynote session and our keynote speaker. So we know at a time where everyone was looking for PPE, obviously one province stood out and had certainly a strong plan that was, demonstrated over and over again, and not only were they able to supply PPE for their workforce, but also share with other provinces. So this morning, it's my pleasure to introduce Jitendra Prasad, or better known as JP in our community, who will be talking about certainly the successes that they've had. JP was the Chief Procurement, Sourcing, and Contract Management Officer for Alberta Health Services for many years. He has recently retired, but is still very, very involved in supply chain resiliency. He holds a bachelor's degree in pharmacy and a master's of business administration from the University of Alberta. We've had the pleasure of having JP at our table at GS1 for many, many, many years, and we are very grateful for his contribution. So without further ado, JP, the floor is yours.
Thanks. Welcome to Alberta. For those of you that have traveled from out of town. A great privilege to be here, and again, our partnership goes back many, many years, and always a pleasure to be part of these events. Before I start, a few things just to open my remarks. So one, today is a great day for many reasons, but one of them is today I get to wear a suit because, haven't had an opportunity to wear one, and being a supply chain person, I actually went to the right locator code in my wardrobe and I found my suit jacket. So, I actually treat that as success for today. The other piece that I wanted to say is that while I'm delivering a keynote address on Alberta's success as it related to pandemic, I wanted to say that everybody, I think, did the best that they could, and everybody had success, because if we didn't have success in all of the provinces, I think as a nation, Canada would have failed to respond to COVID. So whether it be the federal government, whether it be all the provinces, the provincial governments, all of the health authorities, for those of you that are here, and for those of you that are online, thank you very much, because it was everybody's collective effort that I think really brought us to where we are today. Alberta's story, I think by sharing that with you today, you may relate to some of it. You may actually say, yeah, we could learn from some of it, or you could come back to us later and say, well, maybe we could have done it differently. But I think collectively, that is what a community of practice is all about. It's about making sure that we can learn from each other and making sure that as we move forward, we can fix what we thought should have been fixed, build on those things that can be built on, and keep the successes that allows us to better respond as we move forward. With that, let me get going here before I get too carried away. So let me see if I can see this a little bit here. There we go. So the way that we've approached this presentation is really looking at some of the precursor initiatives that Alberta had in place already, or had initiated or started, that actually helped us lay the foundation to respond to the pandemic. The other thing to look at is an evolution of supply chain, which really I think for a lot of us, sometimes we don't understand sort of the magnitude of supply chain, whether it be in healthcare or non-healthcare. I think supply chain actually pins the sort of the foundation for everything we do. In the news recently, we've been hearing about whether Alberta is going to have enough transportation rail cars to ship grain to the different ports for export, right? That is a huge issue. It is a supply chain issue because at the end of the day, if we don't get that grain out, there is going to be other residual or what I would call impacts of those, things like famine, starvation, inability to feed people. So the reality is that supply chain, nobody used to see it before. It was the invisible force that kept things going. And because nothing ever broke, nobody actually spoke about it. In a healthcare system, for those of you that have been around for as long as I've been, the only time somebody picks up the phone and calls a supply chain guy is if they don't have the product. I have never in my life received a call from a physician saying, I'm really happy I actually got all my implants today. I did get a call saying, USOB, why did you not get the product to us, right? So that's really what defines supply chain. It is the glue that holds everything together that you don't see. The only time you see it is when it starts cracking and it actually starts not being connected, because it is really a chain. It's a chain of events that leads you to where you need to be. And part of that look is for people to understand that it impacts our everyday lives. In terms of Alberta's response, there were some key features. Data was a big part of it. Engagement, collaboration with other stakeholders, and then the structural system and setup in Alberta that actually allowed us to respond in the manner that we responded in. And some of it was, the structure of the organization, structure of the systems, but a lot of it had to do with people. People coming together collectively to be able to deliver the results. And that's really, really important in supply chain. A lot of times we forget that it's the people that actually makes it happen, not that it's the systems that make it happen. So if we had data, we had data because people could take that data and do something with it. Just having data wasn't going to help us get to an endpoint. And then really wanted to spend a few moments on domestic suppliers and what we did during the pandemic, what we are doing now to domestic suppliers, and maybe a look at what should happen as we move forward in the future. And then some concluding remarks just to basically sum up the presentation. So some of the precursors for Alberta's response to the pandemic. One was there was a lot of experience in Alberta in terms of planning for what I would call disaster management. There has been a lot of things that have happened. And I think if you go back, we all planned for Y2K. I don't know how many of you even remember the planning for Y2K. I spent hours and hours in meetings planning for an event that came and went, and then we said, what was that? Like, what happened? Where's Y2K, right? And then everybody said, you know what? Should never plan because things like this don't happen, right? We obviously did a lot of things as it related to Y2K. The other pieces that have happened in Alberta, obviously, and has happened nationally, SARS. We all responded to the SARS pandemic, Ebola, right? But specific to Alberta, there was the fires in Fort McMurray, and there was the fires in the Slave Lake. Those were events that truly impacted the healthcare system for us, right? We were given the task during the Fort Mac fire and the fire previous to that of being logistics managers for the province. I had never thought that my job would be to figure out how to charter planes, how to do booking for people to get into Fort McMurray, how to get police clearance for those people to actually have the ability to get into a hospital to work. We owned the reservation rights to all of the rooms that were available in Fort Mac for that period of time, right? And that requires you to be able to, what I would call, reinvent yourself every day because you needed to do something different. Kathy's here actually from AHS. And, we've had many of these events where, we're looking for things like porta potties. Who would have thought that that is a supply chain job, right? But that is really how supply chain underpins everything. The availability of some stockpile that we had been, when AHS was formed, we basically took all the stockpiles from all of the health regions and consolidated it. right? So that gave us a starting point for where we thought we could start. We had a centralized ERP system that allowed us to actually do a lot of things. We'll talk about that later, but data, the ability to move product, the ability to overnight become a distributor and actually be able to function as a distributor by getting all products coming in centrally and then basically allocating those products to the different hospitals based on need. And then the ability to track demand on a daily basis. What is your burn rate per day, per site, per zone, per province, right? And those were the things that actually became very helpful. We do have in AHS a dedicated emergency management program, extremely important. And they had a lot of experience in being able to stand up the appropriate structures to enable us to do what we needed to do. I've already spoken about the large-scale disasters. Single organizational design. We did not have to work with, or what I would call internal competition. We didn't have multiple health regions competing for the same product from the different vendors. There was only one point in AHS, which was AHS CPSM, and the vendors knew that for any medical products, that's all where you could ship. We then became the distributor for long-term care facilities, for physician offices, for everybody. But it was that ability to bring everything into our central warehouses, and the vendors knew that they could not ship to anybody else. There was only one point of entry. That was it, right? We also looked at a collaborative and engagement model that we had already built within the organization, which we then had to expand because as part of the pandemic, it wasn't just about internal engagement anymore. This was the time for supply chain people to be at the forefront of the fight. Every disaster brings a certain profession to the forefront to basically lead a certain aspect of it. During the fires in Fort Mac, if most of you may remember, it was the fire chief who was basically the face of that fire response, right? That's what happened here. Supply chain stepped up and actually ended up becoming, to a great extent, that engager of everybody to make sure that people understood, you know, that the things that were being done for a reason, and the fact that we needed help was communicated very, very widely to everybody. And I think finally, the experience of the team. So I think some of the team members are here, some of the team members may be, you know, listening online. That experience, but the other piece was the trust that they had. I was actually listening to a talk yesterday from Indra Nui. Most of you know her as the CEO, former CEO of Pepsi. And one of the things that she said is, a leader doesn't always have to know everything and do everything, but the decisions that you make and the way you present yourself and how that filters down the organization actually determines the success that you're going to have or the failure that you're going to have in any initiative that you're undertaking. And I think that was what, as leaders, we were trying to do to make sure that we could keep our staff motivated because they were in the same boat as the general public. I mean, they were being exposed while they were in hospitals, right? These were staff that were still stocking carts, staff in the warehouse. We had to think of contingencies of, so what happens if 20% of our staff get sick in the warehouse? How do we make that an emergency service? How do we get staff deployed from other areas of the organization to actually keep the warehouse running? So all of those things became part and parcel of the response in Alberta. And while we were at it, we also had some fun, right? I mean, at the end of the day, you can't just be working all of the time, right? So there are some anecdotal stories that I'll share today, which I never thought as a supply chain person I would actually be involved in, right? There is a definition of supply chain. I don't want to bore people with the definition, but I always like to make sure that I ground people in the fact that supply chain is not one event. Supply chain is an event that starts from the moment someone thinks about an idea that is to be translated into a product, that can be translated into a service, and how that actually transfers itself from one to the other to the next, and how it influences the outcome is really what supply chain is all about. And that's why I've always maintained with my team, supply chain is the glue that holds healthcare delivery together, because you can do whatever you want, you can say whatever you want. If you don't have those products at the front line for those people to use, there is no healthcare delivery, because you will not be able to get people to go to the front lines to provide that service. Think about the procedure masks. Something that we all took for granted, right, became the biggest commodity. And that is one of the reasons why when you look at supply chain is really about partnership and trust, right? So sometimes we forget that, right? And it's a partnership and trust between the vendor, the consumer, the public, and then those that basically make decisions. So basically everybody. Without that very, very focused approach, you are not going to have supply chain. Entering into a contract is not supply chain. It is simply a tool or one link in the chain that's going to get you to the next step. It's basically how you move forward one link at a time. One link breaks, you have to go back and figure out a way to fix it, because if you don't fix it there, multiple links are going to break in the future, and you then have a harder job fixing those links. So always my focus has been, yep, there's a problem, fix the problem today, but please go back and look at the root cause, because if you don't, you're going to have that same problem over and over again. This is just a very basic schematic of where supply chain is. In the 60s, these are all functions, right? Great functions, but we looked at it differently. You go to any, and I remember even talking about healthcare in the 60s with some of the people that were around then. It was very, very fragmented. I mean, the purchasing guy never spoke to the warehousing guy never spoke to the clinician never spoke to the purchasing guy, and basically everybody did their job and you stayed within your silos. But as we have moved forward, I think there's been a greater recognition. Are we where we need to be today? I don't think so. But I think the pandemic was a great opportunity, right? Because for those C-suite personnel, if they didn't know supply chain then, they probably all tried to figure out where the materials management department was and how the hell do I go and find these guys and at least say thank you to them, right? And if they didn't do that, that's not right either, right? But the pandemic did a great service to supply chain in some respects, because it made it so widely known that everybody now, if there's a problem, the first things even lay people say to me, is it a supply chain issue? And my question to them is, what do you know about supply chain, right? But everything is becoming a supply chain issue, right? And in actual fact, it is. Like the war in Ukraine, if you look at that, if you read about it in detail, Ukraine's responsible for 50% of the production of a product called neon, which is used in creation of, for lasers that are used in the manufacturing of chips, right? Russia manufactures or is one of the world's largest manufacturer of palladium, for example, also used in that same product. Now, if you don't have that product, I mean, for most people, generally you're going to say, well, so what, right? Well, unfortunately, all your computers need it. All your medical equipment needs it, because all your medical equipment now is computerized, right? And so at the end of the day, all of those things start having an impact in your ability to deliver service. And you can see that the impact of some of those things are not going to be seen for the next 5 years, right? So imagine if we think we have a problem today, this problem is only going to get compounded as we move on. So supply chain in the public eye, right? Supply chain is now basically every healthcare organization, non-healthcare organization's problem. I was, talking to someone, and I think this was last week, where they said they have 3,200 products in their system that are active disruptions that requires a substitute product. Now, that's a healthcare system. Can you imagine in a healthcare system, if 3,200 items, you're looking for an active substitute, it tells you the extent of the problem, right? And so really from a supply chain perspective, you have hospitals playing whack-a-mole. You basically solve one problem, there's 10 others. I was actually talking to somebody yesterday that told me in one day, this one individual was provided 67 different supply disruptions that they needed to deal with yesterday. That was 1 day for one person, right, for products. Now that becomes a huge challenge, because can you imagine staff that should be doing things like sourcing, should be looking at, rationalization of products and things that you normally do. You're basically spending all your times now looking for, where am I going to get the product? Because remember, at the end of the chain, there is a patient waiting to get services. So this isn't, a skip the dish delivery that's been missed. and you can maybe go to the next restaurant or maybe order something else on the menu. I was having a very enlightening conversation on home care yesterday with someone, right? And we were talking about how to redesign home care services. That is a supply chain issue, right? Home care is also supply chain, but it's workforce supply chain related, right? How do you measure the service when at the end of the day you get a call from your caregiver saying, sorry, we're canceling your visits for the next 5 days? And you say to them, this is not a grocery delivery, guys, you've just missed, that I can go and get it myself. There is someone waiting for care. The wound hasn't been dressed. They haven't been cleaned. They haven't been given a bath for the day, right? You can't go back and fix the problem, right? So the issue is, how do you measure your success? You measure your success by whether the patient got the service or they were canceled for surgery because of the fact that there wasn't a product. 3,200 substitutions, 67 in 1 day. That just tells you the problem is going to keep compounding as we move forward. In simple terms, supply chain disruptions also means that, maybe you can't give out any Halloween candy if there is a candy shortage, right? Maybe Santa will have to say one day, sorry, kiddo, your gift didn't come because we had supply chain issues, right? Or maybe we used to be rich until we started buying groceries and realized we couldn't buy groceries. That is a supply chain issue, right? All of the things that we are seeing right now are impacts that are coming up. We may be looking at it purely from a healthcare perspective, but look at it from a general population wellness perspective. For the kid, that Christmas gift is really important, impacts their wellness, right? May not be the worst thing to happen to them, but it does happen, right? So we just want to make sure we keep it in context that supply chain isn't something that we are all going to basically solve the miraculous problem, because it is very, very complex. We have to work together to be able to solve the problem that I think has taken years in the creation of those problems. We now need to figure out what are we going to invest to make those problems go away. If you look at some of the other things that has happened, for example, that have contributed to this. So healthcare, all healthcare workers were sent home. Let's go home and work from home, right? Well, we ran out of computers, right? So where does the workforce come from? Then there is the question of equity within the workforce that caused a huge issue in Alberta as well. Well, you have 20% of the workforce that can work from home. My warehouse workers aren't happy. They all have to come into work, right? How do you keep morale up in a supply chain organization when you can't even satisfy workers from the fact that, can't take time off because, hey, I need you to work 18-hour days, right? And then you get the equity issue around, well, either you're out of scope or you're in the union. Well, the union people can claim overtime, the out of scope people can't. All of those things contribute to the ongoing issues. There's a whole bunch of other things that, we can probably skip. But the one thing that we need to be very careful about recognizing is what was different with the pandemic. If we have all of this experience and we have all of these precursors, what changed with the pandemic that forced us to relook at things differently? I love that picture. There was an exponential increase in utilization, and I'll show you some of the data around it, right? This was a public-facing discussion on supply chain. The masks are good, the masks aren't good, right? The masks have insects in them, you're trying to clone us. I mean, I actually have a scrapbook that my kids created for me of all the comments on Twitter and all of social media about supply chain that had my name in it, right? It's pretty thick, it's about 30 pages. They started with the positive comments, right? Because there was one rule in my house during the pandemic. We are not going to discuss what's in the media around supply chain, right? And it's quite interesting. I went from, in the first page, to being the hero with CPSM, to being a conspiracy theorist with Dr. Theresa Tam, and that there should be a Royal Commission of Inquiry, and I should be sent back to China. The last time I checked, I didn't have Chinese citizenship. But that was the theory, right? So it was very, very public-facing, and for supply chain people who are not used to that, it was like a roller coaster. I remember submitting a resignation letter to Werner, my CEO at that time, because I said, if I failed you because of these media reports, I don't deserve to be here, right? But that was the impact that we had for supply chain as we move forward. Length. Who thought 3.5 years later would still be responding to the pandemic? When I went into the EOC, I thought 6 weeks, we'll be out of here. But decided we had to go remote. Couldn't stay in Calgary for 6 weeks, right? Because we also needed support at our homes, right? And so that became an issue. And then the fact that this response included all levels of government, which meant that as supply chain professionals, you had to change your way of thinking because they wanted things in a different way. When you work for an agency, we have different ways of producing documents. Then you have to provide it to the provincial government, totally different. And then if it goes to the federal government level, well, you can only speak to them through your provincial government counterparts, right? And so it was, it was challenging trying to be able to figure out how do you actually do all of these things. The unpredictability, we didn't know what was going to happen from one day to the next, right? And then there was focus beyond healthcare. I think within a matter of 2 weeks, we became the supply chain distributor for healthcare products in Alberta. Didn't matter who you were, whether you're the meat packing plant or you were the, vulnerable shelter or you were schools or whatever you were, you're going to get the products from us. So not only did our demand go up internally exponentially, now you're trying to figure out how do you estimate demand for all of these areas that actually don't have any data. So now you had a supply chain system that relies on linear data, right? Suddenly you have all of these non-linear events and you're sitting there thinking, okay, well, what are we going to do with this, right? Because at the end of the day, all of your past projections, it's done. Throw it away. It wasn't going to help. There was nothing. We had to figure out the predictability of the models that we were going to create in order to get to that endpoint. So, using data to plan, right? So the government at that point said, let's look at what are some of the scenarios. So obviously there was a lot of data from the UK, there was a lot of data from Canada as well. The Alberta government basically looked at 3 scenarios, right? So we looked at extreme, we looked at elevated, and probable. We use this as the foundation for all of our data planning for supply chain because now, once this was done, the next ask from the government, within 3 days, they wanted us to estimate PPE utilization. What are we at, what do we have, and what are you going to order and where are you going to get it from, right? So basically now we have, trying to work all of these things in. So in each one of these scenarios, and this is for wave 1, you can see that, case in Alberta came in around probably, I think it was the end of February. Canada had its first case end of January, I believe. And there was all of this talk of when was things going to peak? Because what we wanted to know was what was the planning horizon that would allow us to get product, and was the peak going to be a normal distribution, or was it going to be shifted right, or was it going to be shifted left? Each one of those had its own complexities because each one of those had an impact on timelines, right? And every healthcare organization, and I think for those of you that are listening or here, healthcare organizations generally don't do global sourcing. We rely on our partners to do global sourcing, right? So now the question is, if your regular suppliers are not going to be able to provide, you can plan all you want, how are you going to find product in an environment where people are going around with suitcases full of money and buying product of planes that are leaving from airports, right? I mean, for all supply chain people, did you ever think that you'd be competing on the global market to buy procedure masks? I mean, imagine playing the stock markets that way, right? That's what we were all doing, right? Practically trying to figure out how do you get products and find the right partner that could actually get you those products, right? Because it was a whole new world at that point in time. So, and this was what came back in terms of the model from a hospitalization and ICU patient standpoint. And there's a huge slide presentation publicly available on Alberta Health's website, right? It shows you the probable peak of 818 patients, ICU peaking at about 244. And in this scenario, the model had shifted in that direction, which meant that there was a slower ascent to the peak, right? Which made us really happy because we thought, if we're planning on this model, this is going to be amazing, right? Well, not amazing, but you know what I mean. Better than, the other scenarios. And then obviously the elevated scenario moves a little bit this way. So we had to figure out how we were going to actually use all of this information and link supply chain data now to patient data. And that really was the big challenge. So we looked at a model that basically said, we need to define the input. So the input is the rate of infections, the hospitalization rate, ICU admission rate, and then within ICU admission rate, ventilator utilization rate. All of those things became absolutely essential. We also then had to look at, because we are an all-in-one system, we then had to look at, what does this look like for acute care, ICU, we've already spoken about, and then what does it look like for EMS? What does it look like for emerge? What does it look like for home care, continuing care, community physicians, all of those things, and what percentage of those patients or staff are actually going to need PPE? A lot of it was, just that. It was basically, we were estimating what was going to happen. And then we looked at that in a 16-week timeline, and we figured out, based on that, how we would expect to see PPE utilization. The other thing that we had to look at as well was basically building in escalation factors to say, so what happens if the model is wrong and the surge goes higher than your 100% that you're planning it? So how do you adjust for 120%, 125, 150%? And then the other piece was, what they said is that, the average length of stay was going to be 10 days. Our model was based on a 7-day week. So what we had to do was then take the 3-day and figure out how the 3-day actually fit into all of the subsequent weeks, because that also adds patient. And the other thing to remember is those additional 3 days meant that that patient was sicker and was probably going to end up staying longer. So those were things that you had to look at as you were trying to do this planning. And the interesting thing with this, and I'll go through each one of these. Interesting thing is you're trying to do all of this while you're working from home in a virtual environment when you have no experience working virtually. We are so used to being in the conference room, whiteboarding it and everything else. Here I am in my basement, sitting down, trying to figure out at 2 a.m, is this model actually going to run and is it actually going to work, right? And trying to get as best advice as you possibly could. So if you look at this, in the top, that corner there, those are the inputs to the model, right? And the way we built it is, we built it for mild, probable, elevated, extreme. So you could actually change this. This change of one parameter would actually change the entire model in terms of your utilization. So that's how we did all of that. And then if you look at the ICU PPE estimates and the admission, what we said is, if these are the PPEs, how many times are they going to change? There were 2 scenarios to choose from. One was, every time the nurse goes in, you're going to change, throw, use new one. The other model we thought was, well, maybe the other model is they would have one staff assigned for a 12-hour shift, so they don't have to change as many times, because for us, you're grasping at straws trying to figure out, we're not going to be able to get that many PPEs. Come on, guys. So we've got to figure some of that stuff out. But we came up, and so in terms of N95 masks, for example, we said we cannot afford a 100% change rate for N95 masks. So what we did is we reduced it to, say, 65% for staff, and then there was a 35% adjustment as well. But those were all stuff that we did that was basically based on estimates and some experience clinically in sort of understanding how ICU and inpatients were actually going to be managing, right? The other anecdotal thing that came up through all of this was, how do you actually provide some of the services from outside the room? So they came up with the idea saying, we'll keep the IV pumps outside. Amazing idea. What everybody forgot to factor in is those IV tubes, they aren't that long. So now everybody's looking for extensions when there are no extensions, right? And they're saying, well, if you don't get us that, then we can't provide IV infusions, because really going in that many times means that many PPE changes, right? So all of those things, as people made clinical decisions, slowly they realized that if they didn't keep us at the table, it was not going to be successful, right? And then the same thing we did for your home care, continuing care. The way the model was built is you could add a table and add other populations to it. So when they came back and said vulnerable populations, we said number of people, here's the estimate for that. When they said, corrections, for example, okay, here's the estimate for corrections. We kept adding to the model through that process, right? And so this was sort of the input. This is just some of the output. Very busy slides, right? But what it shows you is that by inputting those numbers, you basically had all of these calculations that were being done. And, thankful to people who could actually program this. That was really, really great. But the good thing is we actually had data to be able to feed into it. And so you basically had all of these estimates, and then you could actually add contingency volumes that gave you volumes. The bottom here is basically showing you the 16-week normal distribution, right? This is what we use to be able to predict what I would call the peak. The unfortunate part for us was the normal distribution shifted in the direction we didn't want it to shift. It peaked sooner, right? And that meant that, there was more that we had to do. It wasn't the end of the world, but at the same time, it did, create some challenges for us. Now, this is only the PPE side of things. The same thing happened with ventilators. You had to go back, do a full provincial inventory, and then similar models were created for all of the ventilator accessories, right? How and what to buy. Looking at upping the inventory, 25%, 30%, right? And then for respiratory, same thing. If we can't keep patients in ICU and the ICU capacity isn't there, how do you make sure that you can support breathing in patients without bringing them into ICU? So you had to create respiratory hubs, right? Across the province, which would be where you could provide more supportive care as part of, providing them that service, but not having to pull them into an ICU and using a full-blown ventilator. So those were things that were looked at as well. This is just an example. So by the time this goes to government, you need to be able to provide a whole bunch of other things for it. And this is the summary that executive and the ministers and the premier's office wanted to see. They basically wanted to know, after all of that millions of lines of data, this is what it basically came down to, right? They wanted to know, in each one of the scenarios, how many days supply you had left. That was all the information they wanted. And that was only because they saw the details of the model. And for those of you that don't know, our former Premier Kenny, was a very detailed person. He loved the details. So I attended a few cabinet meetings to be able to walk through all of the details with him. So once he understood the level of detail, he understood, I probably had grilling at that committee for about 1.5 hours on all of the things we were doing, right? And after that, this is the information that went up, right? And you can see by the end of June, if we hadn't gotten the support from our vendor partners, we would have been -11 and -13 days. Those were the things that we were working on avoiding. I was okay if that was 0. I was not okay if that was in minus, because I also knew that just in time, we'd be able to get some of those products in and we'd up that number the next week, right? So that's really a snapshot of what. The one that we watched the most closely was really the one around N95 masks, because that was the one that I think everybody had challenges with. And this probably just an explanation of our supply chain model, which really is around, how do you make sure that you can keep planning? Because the complex model, based on the all of the information after wave 1, we actually didn't have to go back to that, because we now had enough retrospective data that we could actually switch to a supply chain planning model. And the supply chain planning model now worked on 2 pieces of information. One was on what I call the probable and the elevated scenario utilization, and then what actually happened. And I don't know if this is the experience of most people. From us, the actual was always lower than the probable, because our probable was, probably set at a little higher level, except one item, which was gloves. Our glove utilization was twice what it was supposed to be in the probable scenario. And to this date, we don't have an explanation for it, other than the fact that we thought maybe people were using it more, maybe they were double gloving, but that was the only one where the model was very different from what the actual showed to what the model was. And so we basically switched to a very supply chain model. Not going to bore you with the details, other than that was a model that allowed me to put in 20 days of buffer stock, 40 days of inventory, and it would basically spit out what I needed to do for the next 6 months in terms of buying, right? So basically, the ability to do all of those things using those models was really quite exciting. And you can also see that we were getting tremendous amount of stock from the federal government. Now trying to figure out integrating stuff from that to what we were buying to what we could actually move out through the system. And we actually ended up saying no to a lot of items from the federal government, because the end of the day, we just couldn't integrate, and people just weren't willing to switch back and forth from product. For us to switch a product, you had to change about 10,000 locators in the province, right? Because that's the way our system is set up. That's the way we are in terms of a distributorship, right? Our staff were tired of making changes constantly. So we had to figure out a way of giving them stability, and the best way was to say, here are the products we actually don't want to use. And then there are some items where there were no models that were going to work. Disinfectants, for example. We can't really estimate how many sheets people are going to use. So at the end of the day, those we basically switched to RTUs, right? And again, a lot of heartache in terms of moving people away because they're already busy. Now you're saying to them, hey, you actually have to spray and get a towel to wipe your countertops as opposed to just pulling out 2 sheets and wiping. Because people and workforce were tired. So every time we made that change, we had to go through an extensive engagement process, which we'll talk about in a bit. Our planning was for the entire province, so we got data from the government. We had our data, we put it all together. Here's what we're going to buy. The understanding was if it was a healthcare product, we would buy it. If it was a non-healthcare product, they would buy it, which worked really well. Just an example of overnight, we scaled up. We added 1,700 to 2,000 external partners. These are all of our long-term care facilities. These are all of our private EMS. If they needed PPE, they had to be serviced through us. So we overnight created a third-party sales program, which in the beginning was very, very manual. And then we scaled it and put it on our web so people could actually go in and say, yeah, send me this. We also had to man a 1-800 line. If there was a COVID outbreak at 3 in the morning and that site needed supplies, long-term care, Kathy was the one that got all of those calls. She would wake up, phone the warehouse, dispatch, and that's what we did. There are some really interesting stories too. When we started, the first shipment of masks that we were to get from China came 12 hours after we issued our last mask from the warehouse, right? That was the window that we had, right? And kudos to the vendor community. They came, they delivered, we got the product by 9 in the morning, and it was shipped out, right? But that was the level of collaboration that was needed, because if it wasn't there, we wouldn't have been able to survive. Same thing with a whole bunch of other products. Isolation gowns, I still remember the night we ran out, and we were expecting shipment from the US, and you know, it was about 3 in the morning, I just went to sleep. I said, I just can't do anything. I'm done. Like, if it's not there, I just have to face the music tomorrow morning, right? I get a call from my warehouse manager, and some of you may know Steve Bowers. JP, he wakes me up at 5. He said, good news, there's a truck rolling in, and he said, I think they have 25,000 gowns. That was like the best Christmas gift I've ever received, right? We made and milked those 25,000 gowns for another 1 week before we were able to get additional stock in. But that was how close we were cutting it, right? And that's what made it so difficult. Trying to look for N95, I don't know how many organizations, and I don't know if some of you have this experience, people selling N95 masks. It's there. It's in the free zone. $8 a mask, advance payment, we'll get it to you, right? You know, and so, you know, we had a lot of those types of stories. But there's one story I will share. And it's a really nice anecdote that I think I still look back and I smile sometimes, is we were having this discussion with a group out of Bolivia for N95 masks that they were actually going to bring through into Turkey, into the free zone, and life was going to be great. We were going to pay them and all that stuff, right? All of it kind of fell apart, as you would probably guess by now. I think it was that night or the night after, I was fell asleep and I'm dreaming about N95 masks. And I mean, that's how bad it was, right? Dreaming about N95 masks, and I'm seeing myself in this alley. You know, I'm backed up. We're negotiating pricing for this N95 mask. We make a deal, right? Time for payment. They said, yeah, we take Amex. I give him my card. The card gets declined. And they shot me. And then I woke up at night, I thought, this is not what I signed up for. I signed up for supply chain, not to get killed, right? But there are a lot of those stories, if you look at physicians in the US who have published stories of how they were meeting all these people in these shady parking lots, trying to get N95 masks. That's how desperate we were, right? You have no idea that during that time period, you know, I think our families probably thought we were crazy. I used to work in the basement, and if they didn't hear me talking because I talked all day in meetings, they would come down to check to see, did something happen to him, right? Because that was the level of stress, right? I still remember the day that the first flight landed in Alberta with masks, right? I mean, Pepsid after Pepsid, and you're trying to figure out, how to get, just stay sane, right? But seeing that plane land was probably one of the most amazing things. Now, even though after that we had a lot of media issues, but, it was great because finally we knew we could do it. We could actually pull product out, and that was really important. Just a whole bunch of other things in data. If anybody wants more information, happy to share this. This is just summarizing all of the data. This is how we presented data to all of the stakeholders. And then we really had to dumb down data for our stakeholders internally. So we took all of this and created a manual spreadsheet. It was very simple. It basically said, here's how much the burn rate is per day compared to next week. And here's what it compares to in terms of actual utilization to date, the probable scenario, and the elevated scenario, right? It just gave them some level of comfort that we had stock in hand and we were going to be okay. The good thing is, if you look at the first line, goggles, we used only 3 per day pre-pandemic. We peaked at about, I think, 1,000 it was, right? But it gave people a sense for what that increase looked like, because when we speak about exponential demand, that's what it was all about, right? Engagement and collaboration. This is probably the most different in terms of what I've ever experienced in other supply chain events. Because it wasn't engagement of the type that we're used to with just clinicians. This engagement was very different. It was dealing with a sympathetic public and a very hostile public, right? And it was about telling a story that people could resonate with. So when we first had problems with our masks in Alberta, a lot of people were proxies for talking about everything's fine, don't worry about it. Finally, it came down to the fact that somebody who could tell the story had to step up and tell the story. So my comms person came to me and said, we think it has to be you. Had never done a media presence before that. But, at the end of the day, you have to be able to make sure that people are getting the right story, right? And so that became the most public thing that we've ever done, is basically now standing and being grilled by a bunch of reporters about the quality of the masks. Why do you think it's okay? And then basically the commentary that comes after that. He doesn't know what he's talking about. That's not true. I know more, right? Those were the types of things that we were dealing with from the media. Now, as the pandemic progressed, it got better, but other things started coming into play. So another anecdotal story for you. We had people that actually would go into Emerge, steal the masks that were on the shelf, and then they bought microscopes from Amazon, right? And then they put it under microscopes, and then they put this out in the YouTube domain, talking about how the masks that we brought into Alberta had these insects in them, or the fact that we had some sort of chips in them because we are trying to infect the people, right? So you have all of this stuff in the media to which, you can't even give a sane rebuttal to, right? But at the end of the day, those things all just kept compounding, right? It just kept growing, and it does take a toll. And after a little while, we just said, just not going to respond to it. What do you want us to do, right? Wherever the mask is examined, everything's fine. And last time I checked, I really actually didn't want to control anybody, right? So not really quite sure why everybody thinks that's what it is, right? But that was the conspiracy theory of the time, and I think it continues to be today, right? Some of the other ones was interesting is, even the the collaboration with Health Canada, the federal government, the provincial governments, public, right? Making sure that people understood what you're trying to do and that there was no need to panic about the medical supplies that were there. And then I think the one piece that really worked well for us was the engagement with our unions. Right at the outset, within, I think, a week of the EOC being set up, we met with United Nurses of Alberta, Health Sciences, AUPE, and any other union. I think QP was there at the table as well. The goal was to be transparent to them and tell them exactly what we had and exactly what we could do. And asking for help in sort of creating the policy for the use of N95 masks and other PPE items. And that became a weekly occurrence for us. And that was probably one of the best things we did as part of engagement, because we had such great support from the unions, because they knew transparently how much stock was in the warehouse at any given time. So anything that was a myth was dispelled by them. We actually didn't have to do a lot of it. And the other thing that really it helped us was we made sure that as part of our engagement to bring in new products, we created this task force of about 150 people that would do a rapid fire test of the product that was going to be brought into the system. And that had all of the WHS officers from the unions on them as well. So if they were part of the process of bringing the product in, they could object when it was time to object, but they couldn't object when it wasn't. So some of those things became a huge issue. The other thing was a public relations issue. You're trying to get product out of China. China wanted products for themselves, so labeling was an issue. They did not want the products labeled for medical use, because if you did that, you wouldn't get customs clearance. So some of the N95s that came, they clearly said not for medical use, but N95s generally are meant for industrial use anyway. It's only few models that are meant for medical use. Now, trying to explain that to a staffing group that is already riled up about everything, I still remember that we created an 80-page document to substantiate that. And then we had a complaint put into the Public Interest Commission, I believe in Alberta, that's what they're called, that we actually did not do a good job in informing staff about those things, right? So at the end of the day, those would be some of the things that, we did. And I know I'm running out of time, so let's move to the structural benefits. We had a centralized structure. We had been at it for 11 years. We didn't have to recreate the structure. We didn't have to recreate anything. We only had to figure out a model that allowed us to work very closely with government, right? The rest of it, the infrastructure was already in place. The ERP was already in place. The systems were already in place, right? So the ability to scale up, scale down, the ability to move product from one site to another product, all of those things, which I'm sure all the regions did. We just didn't have to figure out, is that RHA also getting product? Is there another RHA that's getting, those things just didn't happen, right? So structurally, that was really important. And as a result of it, we were able to bring all of the other sectors in as well. When there was time to go back to school, for example, the school reopening plan, right? We were given about 6 days notice to get rapid test kits and procedure masks, right? Because one of the things that they said is, we actually trust your ability to scale up and distribute. My team didn't feel that way. I'm sure that there's some of them that are listening here. I still remember some of the very heated commentary about, well, why would we do that, right? The question wasn't about why. The question was, we have to do it. I understand that you are looking for 3 weeks to do it. Let's see if we can do it in a week and a half, right? And by the way, the school's open in a week. So that's about the time we can buy, right? So those are the conversations that we were having, is how do we make sure that you keep our staff motivated to do everything that's being demanded of us, while at the same time delivering to what the government wanted to do, because ultimately it boiled down to, if you don't have the rapid test kits and the mask, schools don't open. Well, can you imagine the fallout from that, right? That becomes an issue. So all of those things were things that we had to deal with. I think the rest of it I've already talked about. We talk a little bit about domestic supplies, and I'm probably take a different slant at it, right? There's really, when you look at Canada as a manufacturing hub, it's not there. And I'm not really sure that we can afford it to be there for everything that we think we should manufacture. Maybe we do. That's just my perspective, right? Some companies are doing really well. Some may not be doing as well. And then the question really boils down to the model, the economic model and the economic viability, right? So when the pandemic was at its full height, there was all of this stuff, local manufacturing, local manufacturing. In Alberta, we had the Bits and Pieces program, as a result of which there was a mask manufacturer in Alberta. There's a cost for that. So, at that point in time, that cost was actually less than the cost, maybe, what we would have been paying for masks coming from elsewhere, right? That's changed now. So do we change as well in terms of how we source? Because that's where the contracting strategies that we have come into play. Do healthcare organizations have contracting strategies that supports locally manufactured products, right? That becomes the big question, right? So then the next part of local is local distributors, right? Who have the ability to partner with external manufacturers in other countries, and they bring in product in a diversified market portfolio, right? For those products where it doesn't make sense for us to manufacture. Maybe there are products that we can manufacture in Canada. Maybe there is going to be an incentive from the federal government at some point to say, we should do this. Maybe the provincial governments are going to come to health authorities and say, it's okay, pay 10 times more as long as it's locally manufactured. If they do that and don't hold supply chain accountable for budget stability, maybe that's doable. But what I'm seeing now is the shift away from buying those manufactured products or supporting those vendors that actually stepped up during the pandemic to deliver products that were quality products, because we are now going back to our traditional base, right? And if we're going to go back to our traditional base, then I can assure you that in the next 3 years, you're going to be back to square one. And this going back to the original base is what's leading to those 67 disruptions in one day. Because everybody has scaled up service. Everybody wants to do 150% more surgeries. Let's face it, there aren't that many implants in Canada that will allow you to do that. There aren't that many sets. There aren't that many medical devices that are used in the OR. You don't have equipment to support that, right? You don't have workforce to support that. That's, a totally different discussion, right? So the question really, I think, for the community of practice is to figure out what is it that we really want to do? Are 10-year contracts the norm to go? Or is it 2 years? Is it to look at a diversified portfolio? Doesn't matter where the manufacturing is done, right? But do we give an opportunity to those so that we can actually have a diversified portfolio? Because at the end of the day, the traditional vendors told me, sorry guys, your contract said you're only allowed 10 a day. I'm giving you your 10, so I'm not sure what you're complaining about, right? I need 2,000. Where is that coming from, right? And then they stopped providing me with the 10 as well and said, sorry, I'm invoking force majeure because we just can't deal with it, right? So I think we really do need to keep that in mind, right? Because if we don't keep that in mind, I think we're headed for some trouble, right? And that's part of what, and then the last piece in domestic suppliers is how do you treat indigenous opportunities, right? Is there an opportunity? Is there not an opportunity? The federal government does provide incentives, right? Is that part of our mandate to be able to support them as part of the Truth and Reconciliation Commission recommendations? Maybe it is, right? So I think there's a whole bunch of things that go into domestic supplies. It's probably more for political discussion, but for supply chain professionals, I think the basic fundamental question is, are we going to be fair to those that stepped up during the pandemic and allow them to continue to be part of the marketplace, or are we going to completely get rid of them from the marketplace and create the same problem 10 times worse in the future? And I think that becomes an issue. Looking to the future, as Buzz Lightyear might say, things might look different. Not sure it's going to be in my future, but it could be. There are 4 questions to ask, I think, based on what I've seen in this pandemic, and this is adapted from an organization that's been doing some research. For everybody's supply chain, do we actually need to diversify the portfolio and the marketplace? And if we have to, how do we do that given our current practices in sourcing and contracting, right? And the processes that organizations have. I know that healthcare organizations traditionally like standardization, right? Because it makes sense from the integration they have in their systems. I would be one of them to say, because of the clinically integrated supply chain that Alberta has, it's a real pain in the rear end to bring in a substitute product. But hey, you're still dealing with 3,000 of them today, right? Why do we keep going back and doing the same thing if we are not going to fix the root cause to see how things can be fixed for the longer term? And I think that long game is what's getting missed, not because people want to miss it, but because you have so much work to do for the problems you have today, you don't have time to look at what's happening in the future. And I think that's the piece that we have to figure out how we get done as we move forward. Local manufacturing, I think it's a political question that does need to be answered. Does Canada want to be a manufacturing hub for PPEs, or does it, and medical supplies, or does it want to be partially into the business? I don't know, right? That depends, I guess, on who's in power, I guess, at that point, right? But how many manufacturers do you support, and who do you support, and on what basis do you support? So where's the question of fairness, right? Because everybody would want to get into that business, right? But where is the question of fairness, and then what volumes can we support? Like, can Canada support 3 glove manufacturers? I don't think so, based on the volumes I've seen, because it's a volume-driven business, right? So that's, I think, what we have to wrestle with. Digitalization, and I know that there is a whole stream on digitalization. Digitalization, I think, is important. It's expensive, but I think if you don't invest in something that is so fundamental and so critical to everyday life, do you think we can survive in the future, right? But again, a very political question. I'm looking at Scott here, and he's probably laughing at me, because part of it is, how do you go to government and make a case and say, you know what, we have to do 10,000 more surgeries, but I want $20 million to invest in a digital supply chain system, right? It's a very difficult case to make. I think Alberta was very fortunate that we were given funding at a time when we were in complete turmoil as we were being created into AHS, and they felt that one of the best signals to send is have a consolidated financial and supply chain system. I'm forever grateful that that happened. Everybody thinks I'm nuts for accepting a project to implement the merger of 13 systems in 18 months, 6 months for the business case, 12 months to implement. If I didn't do it then, I had a very sage CEO at that point that said, that's all the window you have, because all the money after this goes to payroll and clinical systems, right? So you take the opportunity today or you don't get it, right? And that's part of what it was. But yeah, I think it's worthwhile, and maybe it's not full digitalization, maybe it's figuring out an incremental approach to digitalization. And maybe there does need to be, some sort of a Health Canada assessment of where we are in terms of digitalized space. And then I guess the whole customer focus, which I actually look at it and say public focused, people focused, right? How do we make our supply chains responsive to the needs of the people, right? I think we learned that really, really the hard way during the pandemic. People understand the standards. I still remember facilitating a call with a physician who was originally from China, with a Chinese manufacturer that we had, and the argument they were having about the standards. I've never spent this much time trying to understand, the Chinese standards, the Turkish standards, the European standards, because they're all standards and they're all good standards. It all matters in terms of how you're going to create the comparability of those standards, right? And those are all interesting conversations to have. But the only way we could get this person to stop providing media fodder was for her to talk to the manufacturer, the end of it, right? I don't know if we satisfied her, but, she had an opportunity to vent. And the same thing with public, the constant engagement. The other piece that really became an issue was the political environment, right? Why are you buying from a country that may be oppressing a certain section of the population? Malaysia became a big news story because of forced labor, right? But where are you going to get gloves from when you need 1 million a day, right? And so some of the responses I gave was, well, we try our best, but this is the reality, and our plan is to phase it out. And then there were some people that wanted us to look at environmental options when our procedure mask utilization went from 33,000 a day to 750,000 a day. And I'm thinking, not happening at this point, right? So I think those are things that we have to look at. And really, from a futuristic standpoint, from Foley and Lardner, they did this in 2021 or 2020, is really that a lot of executives, whether it be manufacturing or supply chain, are looking at doing things slightly differently, right? 70% are actually changing their focus on sourcing from the lowest cost manufacturer. They're looking at best value. Best value in terms of stability, sustainability, environmental record, labor record, all of those things now play into how we need to source as we move forward. A very tough sell. And I know that Colleen may have dialed in, online. She's a CFO for HS, and I used to work for her. But that is a fact that we have to look at, because we are already spending all this time trying to look at and deal with supply disruptions, right? So is there now some sort of a reset where we are looking at that whole cost equation slightly differently? 62% are putting less focus on just-in-time. How many of you come from the JIT world, where if you have 48 turns in your inventory, you're doing so well, you get a prize from everybody, right? Doesn't work in a globalized economy when a pandemic hits, because everybody does just-in-time, and you have products coming all the way from Ukraine, Russia, China, Taiwan, right? They're all part of your supply chain. Just-in-time doesn't cut it anymore, right? So everybody's moving away from just-in-time, looking at pandemic stockpiles. 43% are looking at alternative sources. I don't want to single out any country, other than the fact that, China obviously was big during that time. People are looking for a diversified portfolio. Can we move to other countries? New hubs for manufacturing. Where are they, right? Can we find them, right? And part of that strategy also feeds in not just to the pandemic, but also feeds into all the natural disasters that are disrupting the supply chain, right? Puerto Rico hurricanes. I don't know how many of you remember a few years ago, no IV for solutions, right? No trays. Not because they were manufactured in Puerto Rico, they were actually done in Costa Rica, but the sterilization plant was in Puerto Rico. Environmental EPA in the US shutting down those factories, Teleflex and all of those. No product, right? So now you have all of those things that happen. Resin factories catch fire. What do? If 2 factories account for 60% of your resin supply, right? And vendor relationships. 42% said that they want to have better relationship with the vendor community so that they can be partners in solving the problem. So at the end of the day, everybody's talking about lead times. This is just from the US Census Bureau that actually showed all of the different supply chain disruptions. The remarkable thing here was how the inventory that people had to sell went down as the demand went up. And really at this point today, most organizations, if you ask them, they don't have stockpiles left anymore, because now they're all basically planning how they're going to replenish that over the next 3 to 5 years. We talked about in Alberta, low, medium, severe, or high supply chain challenges. I actually don't like this, because in my mind, every supply chain disruption in healthcare is high. Doesn't matter whether it's a paper bag for the patient's bedside, doesn't matter whether it's a Ziploc bag, doesn't matter if it's a ready-to-use disinfectant, a towel, doesn't matter. If they don't have the product to provide care, it breaks down the normal routine. It means it takes twice the time for them to do something, which means the patient throughput gets impacted. So if anybody comes to you and says supply chain in healthcare, this is the severity level, there is only one level. There are no levels whatsoever. I'm not going to go through all of this other than maybe to say that what the pandemic did created a tremendous amount of stress. I was speaking at another event and somebody asked me, they said, you have black hair. Didn't you, get any gray hairs? I said, that's the magic of modern technology. I can make it any color I want. I said, after the pandemic, I made it, blonde or whatever you want. And I said, maybe one of these days I'll be brave enough. I keep teasing my kids. It'll be blue or purple, right? But, we'll see about that, right? But at the end of the day, the pandemic, while it did all of these things, also did some really good things. I think it put a lens on supply chain. So if there is an opportunity to make changes to supply chain, now is the opportunity. It's not going to come back again, because if we don't grab the opportunity today, it's gone. And, there was one slide at the end that I don't see here, but it was a picture of, what does it feel like to be a supply chain person? And I think the quote was, it feels like I'm on a bike, riding the bike while the bike's on fire, you're on fire, and the world around you is on fire. And that's exactly what we felt like during the pandemic. Thank you very much.
So thank you very much, JP. That was really, really great. Obviously, a lot of leadership, and certainly thank you to you and your colleagues that are online. Obviously, you've demonstrated that it can be done. You've certainly shown us that planning, methodology, the data model, and I love the fact that you talked about the people. and the experience about the people and what it meant personally for the families and everyone around it, working from home, working virtually, and still having to do this. So I hope you sleep better now at night. I think that scrapbook would be very, very interesting, but I'm glad that your family was there to support you. So we're going to take a short break. JP will be around all day to answer any questions, and then we'll be back. Thank you.